Okay, thank you. That was absolutely fabulous tour de force, and everybody touched on a really different aspect of the issues with the sort of same issues at the core, so great fodder for conversation. While everybody's screwing up their courage and getting ready to ask their question, I think we'll ask you to raise your hand and the mic will come to you. One of the things we didn't talk about too much, and I just wanted to throw this out to each of you, is the issue of governance. When you talk about collective impact, some people would say aligning interests is a kind of governance, but obviously government, which you all represent, is really important. So how do you get the political leadership to take on a health agenda, a public health agenda, in regard to the kind of support that you need? What are some of the obstacles? What are some of the strategies that you've created to make that happen?
Is that going to me first? Well, let me start. Yes. So that's obviously a really important question, because many of the communities that we've all been highlighting as bearing an excess burden of numerous poor outcomes. I mean, not just health, but education, mass incarceration. If we looked at which neighborhoods light up, it's the same neighborhoods, are neighborhoods that are deprived of political power. So in talking about going to neighborhoods, we have to acknowledge that we have also to deal with the fact that the policy environment of those neighborhoods not determined there. It's determined more broadly. In New York City, we're in a special situation because we have a Board of Health that has regulatory authority. That's one part. So our Board of Health, when it votes, it's passed a law. It's outside of the legislative process. So that is one part of it. And of course, the political leadership of the city is important. And New York City, for the first time in 20 years, has a declared progressive political administration, and this is also a great help.
Now you now have microphones. So
yeah, we all have microphones. Yeah. I'll give it to you.
You don't all have to take it up, but if you're interested, please do.
In Philadelphia, we've had the very good fortune of strong support from our mayor, Mayor Nutter, who has been an advocate for public health, predating his term as mayor, as a member of city council, when he led the charge for Indoor Clean Air Worker Protection Act to outlaw smoking in restaurants and indoor spaces. We've had strong support from city council. I think our health departments vary in terms of the spectrum of things that we have under our umbrella, of what responsibilities may be the lead of other parts of city government, but they have a big impact on health. And so we need to be aggressive in working out, or reaching out and working with our colleagues in other parts of city government. I think one thing that's impressed me is that we do need to keep educating our political leaders about what public health is. A striking lesson to me was a number of months ago. We had a candidates debate in our mayoral primary about public health, and yet most of the conversation focused on healthcare. Obviously, healthcare is important, but I think we have to keep reminding our leaders about what public health is and what it is that we do.
Yeah, and I would agree with that. I think it is, it's our great challenge in public health, actually, to keep on putting this at the forefront of the agenda, because otherwise, I think it's easy, especially for our elected leaders, and this goes back to Joe's question about challenges, to do the whack-a-mole, right? You have the issue that comes up and you immediately want that immediate solution. And for example, in Baltimore, when we see violence and unrest, immediately people think about, well, these are the perpetrators. Let's do something about the perpetrators. It takes a little bit of time to then focus on what about employment opportunities or education. And then we can say that we use that opportunity to say it's not just about violence, but violence is so closely tied to trauma. I mean, how many people in our city have not experienced trauma growing up, whether it's with poverty or whether it's with not knowing about whether they're gonna have a house over a roof over their heads. And so how can then we redirect that conversation to talk about behavioral health issues? And so I think that's the challenge, but also the opportunity that we face.
Carlos and then Mitchell, and then we'll open it.
Yeah, just a quick idea. I do believe that we have to partner with the communities and with the other sectors within the city. And a great tool for that is sort of a barometer of what happens when other sectors do a policy and what's the impact of that policy into health. And we have to tell them, hey, what you are doing is improving health. and you are really having added value. So show the added value of some of the policies, and obviously show the lesser value of other policies for public health.
Well, no, I can just think of a lot of examples. For example, I have two microphones. I'm really feeling empowered here. For example, we had a number of very high-profile attacks violent attacks by people who clearly had a history of mental illness. The very public execution of 2 police officers in New York City was somebody who had a long history of mental illness. And as Liana was just pointing out, we can turn that into a criminal justice matter, or we can also, try and bring our political leadership and the population along with an idea that we have to take a longer view of this. So that often for people in public health is a difficult path to navigate, but we did succeed in doing it. And I think that taking advantages of situations as they come up as an opportunity to take them back to public health is really important. We also did an analysis on the impact of $15 more livable minimum wage. That is not a health intervention, but we did an analysis at the health department to show what the mortality impact would be. And that's an example of how we can show our politicians how they'll have a health impact, even when they're not thinking of it that way.
That's great. Okay, yes, down here? Just keep your hand up until you get the mic, and then I'll try to keep track. If you just tell us who you are and ask your question.
Hi, I'm Andrew Issa from Drexel University. I had a question regarding gentrification and how has that changed what's going on around urban health. I know, for example, in Los Angeles, some of the issues that were faced in South Central are now going to Victorville or Vegas. And how have you collaborated with outside counties or cities and other states, and what challenges are faced when doing so?
Well, gentrification, I think, is a very interesting problem because it has both good and bad things, right? I mean, you're talking about the economic improvements, right? We want people to earn more. Of course, what we don't want is for a different group of people to earn more and come into the neighborhood and push out the people who are still earning very little. But I just say that as a way of saying gentrification is not necessarily bad, but it can be bad. And you point out a very interesting problem is South LA, historically African American. And in fact, our health department has Afrocentric health centers there, MLK, Humphrey. And the only problem is that 70% of the neighborhood is now monolingual Spanish speaking. Right. So I have Afrocentric health centers with 70% monolingual Spanish speaking, and the African Americans that are in my county that haven't moved to Vegas, they've moved to high desert where I have essentially nothing. Right, because that's the cheapest place to live, but none of our providers want to live there in the Antelope Valley. So I can't get doctors and nurses to actually be able to serve them. So, while I have no answer, it does fit Lena's point about the dynamic nature of health. You have to go where people are, right? So we have now been opening service areas up in high desert to try to meet the needs of African Americans who are living there, because that's now where it's affordable.
Okay, let's go over the gentleman in the back, and then the lady in the blue sweater comes after. We'll go back and forth. Then the middle has to catch up.
Thank you. Going back to the first question and issue that you were talking about.
Could you introduce yourself, please?
Oh, sorry. Arthur Frank on the EOH faculty here at Drexel. You were talking about the political support that is needed, and I think it's fair to say that in places like New York and LA and Philadelphia, there has been good political support at the local level, and that's certainly necessary but not sufficient. We have a chair of the Environmental Committee in Washington who doesn't believe in climate change. We have a legislative body that's trying to do away at every turn with ACA and taking health care away from people just as you're trying to give it to them. So I'm wondering if you might want to comment at the larger level. how we deal with those political issues, and maybe as a corollary, for those of us that are in academic situations, what can we do collaboratively with you or in our own way to help further education, perhaps not so much at the local, but at the national and perhaps international level as well.
Carlos, do you want to start with that one?
Well, that's not an easy one. Otherwise, we would have had a very successful bond meeting, and that was not the case. I do think that now that I have moved into an academic institution from the Pan American Health Organization, I do think that there is an urgent need for academicians to translate their knowledge to the policymakers and to make an explicit effort. I know that there are also structural things within academia that does not help on that, but I would say that is something that is badly needed. Really, a lot of the knowledge is not being translated to the community nor to policymakers. That would be one thing.
I can say, I mean, I came from the academic world not too long ago to government. I've never been in government until this job, actually, and so I understand more the academic world than I do of government service. You know, I think that there's a lot of fear within academia because we are pretty conservative, and I don't mean politically, but just in terms of the academic institution or medical institutions. And there's this fear of, well, what would happen if we step outside? And how do we really talk to policymakers? Do they want to listen? And I'm here to tell you that they really want to listen. And in fact, that if your voice isn't heard, some other voices are going to get heard instead. And it's so much easier than you might think. So I'll give you an example. Last week or 2 weeks ago was International Overdose Awareness Day, because there's an awareness day or week or month for everything, right? But at least in this case, so you've taken advantage of the opportunity. So we had International Overdose Awareness Day, and we invited our entire federal delegation representing the Baltimore area to all these events. And you know, they gave me naloxone, I gave them naloxone. It was kind of fun. It was a good idea to involve them hands-on in all the various things that we do. And we also invited leaders from our academic institutions and students to volunteer to do outreach trainings and to also educate our policymakers. And I realize this is a small example, but I think that that's one way to really get yourself into these conversations as students and practitioners and professors and researchers in a way that's really tangible, because you can see that it's not that scary, and also that then builds that relationship for you to not only advocate on that one issue that you're there for, but also on the larger issues as Dr. Frank mentioned, on environmental health or ACA and other things too.
Yeah, I just want, maybe while you're coming to this lady who's next, just having been in the Clinton administration on health, I think one of the things that comes up very clearly is really the federal government has very few levers in the public health arena. It has traditionally been, historically, for a very long time, really local and state government led. And so I think that's a dilemma, but you want to know where to go to try to get the issue taken care of that you have to get taken care of. And then the other thing I would encourage, and I would imagine any school that Anna's associated with for very long, will be looking at explicit training of public health professionals in the process of translating evidence into actionable implementation, actual interventions for policymakers and program leaders. So those are two challenges, I think, that are well suited here. Yes, ma'am.
Thank you so much for what you've said. It's been really lovely to hear so many different ideas and different perspectives. I'm Jana Mossi, and I'm a faculty here in epidemiology and biostatistics. I'm an epidemiologist. And you've mentioned, a couple of you, things about the homelessness, the mental health problem, the substance abuse problem. And the question I'm really raising, or the issue I'm raising, is that I see worldwide that mental health is one of the most important limiting factors for the population at large. And the World Health Organization has been talking about major depression as one of the leading causes of disability worldwide. We have suicide is getting to be higher in the causes of death in multiple populations. I see us as in public health as the politicians, as almost everybody, having that be sort of like the big elephant in the room that nobody really wants to talk about. And very little seems to be progressing and being done about it. I mean, the same things, the World Health Organization came out with a major depression issue 10 years ago or before that, and little has changed. And I'm sort of raising this as a question. How do we as public health become more engaged? I don't know that we are. We have very few programs in psychiatric epidemiology. We have minimal funding relative to other areas. And what do we do both locally and at the city level to bring this to the forefront of something that becomes not the black elephant or the big elephant in the room, but something we're actually making progress with?
Okay, thanks.
Well, I'll offer one first solution and pass to Mary some multifactorial solution that's needed. Like a lot of problems that we've been talking about, I think that mental illness has gotten segregated. So I think part of why we don't talk about it in public health, and we should be, is that it's gotten focused as, well, that's the mental health community, right? And so it's dealt with as a narrow clinical problem instead of what it is, which is a broad social community problem. And it's dealt with to the extent that it isn't ignored, and a large part, as you say, is ignored. But to the extent it's dealt with in a narrow clinical focus instead of a broad focus that takes into account the impact of mental illness on the people around the person who's mentally ill and the solutions for mental illness that go beyond the medication, right? That the treatment for mental health is most effective generally when it includes both medical realms and community treatment, socialization, empowerment, recovery, connection. And so I think that at least one solution I would offer is that if the issue is going to be dealt with, it's going to require public health people to engage more with mental health people and show them what each side has.
So this is really a timely question for us in New York City. The First Lady of the city has committed herself to leading the charge to changing the relationship between city government and the mental health of our city. And she uses the same phrase you just used, that mental health has been the elephant in the room, and that we have not successfully leveraged all of the tools of government to ensure that we acknowledge the many ways in which mental health intersects with many other activities that our taxpayer dollars pay for. So the criminal justice system, there was a behavioral health and criminal justice task force that came up with such ideas as drop-off centers so that police don't face the choices of a jail, a hospital, or a mental health shelter, homeless shelter, that they can bring somebody to a place where they could be connected back to care. The health department is going to be establishing those sorts of ideas, retraining frontline workers so that they understand mental health. That came out of the task force. Additional funds went into this problem of violence. This is something that it would help a lot to help us in city government understand how well we can predict violence, by the way. Something that I'm not sure that politicians understand how poorly we can do that. But in any case, and finally, a roadmap will be released. I believe this is not public, but it's in the first week of November is the date that I'm hearing, which will talk about how we can mobilize city resources, the city workforce. You know, listening to my colleagues, New York City is a really big city. We have 350,000 civil service workers. Our health insurance coverage covers 1 million lives. So using our workforce as a major employer in the city to ensure that people are aware of mental health shows real possibility. That's one of the ideas. There's going to be a whole host of ideas, and I think this will probably be a legacy issue for the de Blasio administration. Academia has helped us in framing the problem, and I'm sure we'll turn to academia also for looking for solutions.
I think there is
everybody else has
Yeah, we got more mics than we need.
more mics.
Except she doesn't, but we do.
I think there is a growing awareness of the importance of mental health as a public health concern. When our department a couple of years ago did its initial community health improvement plan and solicited input from a broad mix of different constituencies, one of the three priorities that emerged from that process was the need to better integrate mental or behavioral health and primary health care and other public health services. And perhaps at a more modest scope, there are steps that can be taken. So, for example, the mental behavioral health counterpart for the state Medicaid agency, which is delegated to the counties in Philadelphia County, they've made every effort to facilitate or make it easier for primary health care centers, federally qualified health centers, to incorporate behavioral health, mental health services into their services, and to be able to get to bill for that. Well, that's important. If the primary care providers can bill for that, then that's more likely to get done. Another example is we often touch the same people as our counterparts in the Department of Behavioral Health, which also addresses substance abuse. But we haven't taken the best advantage to be integrated. A great example is around hepatitis C and HIV prevention. We work with the same community organizations that they're working with around substance abuse. And so we've started a conversation about how we can better integrate and coordinate the things that we're doing that reflect the consequences of substance abuse that we're addressing with what they're doing to address the problem of substance abuse itself, often in collaboration with the very same grantees or community organizations.
Okay, I've been given the high sign for 1 minute, so I think we're going to have our last question and then have a break.
Thank you. Howie Frumkin from University of Washington School of Public Health in Seattle. Great presentations by each of you. Although each of you talked compellingly about partnerships, I was surprised how little talk there was about academic health department partnerships. Each of the four local public health leaders comes from a city where there is at least one, and in some cases a large number of academic public health programs. But the academic public health department didn't come up much. Just in the last few minutes of conversation, there have been a couple of mentions in specific areas such as mental health, of areas where the health department may team up productively with academia. But what I'd like to do is ask each of the four of you, Carlos, sorry, this is a local public health department question, either give the best example you can of a productive partnership with a university in your city, and or give us an example of an unmet opportunity, something that you could do in partnering with an academic institution that would help advance urban health.
So we collaborate with this university and many others in a variety of ways in terms of projects that are done with faculty, either because they've approached us and want to do something with our data or our patients, or because we've put out a contract. We have students that come through on various rotations. We tap members of the academic community to be on committees, et cetera, et cetera, et cetera. And many of the healthcare institutions with whom we work are deeply affiliated with academic centers. We're working now with the College of Physicians in Philadelphia to develop a community-wide grand rounds in public health modeled after CDC grand rounds, where we hope to engage people from a variety of different perspectives on a quarterly basis to address issues of shared concern. So there's a lot of that interface, but my gut feeling is that it could be better. It could be more strategic. We could take more effective advantage of that. I think one thing that would be great is to have more opportunities for faculty members to spend rotations with us. And let me tell you, one thing you shouldn't do is send me a letter that says, "Hi, Dr. Bueller, my grant's due in a week. Can you please sign the attached letter of support?" Okay.
Let's have a quick comment from our other panelists. Leanna?
So we have maybe a unique problem in some ways in Baltimore that there is significant distrust of one of our academic institutions. I mean, for those of you who have read the book about Henrietta Lacks, you know that, and I know that there are people from Hopkins in the audience, but that there, I mean, that is an issue in our community. And there is the perception in our community, in particular about Hopkins, but also about other researchers, that research is being done on you if there's an academic institution that's involved. And we see it somewhat too, right? We do see people coming into our health centers, approaching us all the time saying, we have a researcher who wants to focus on this particular area. How can we do research in your health department on this one area? And so we've started to turn this around and instead say, you let us know if you're interested in working with us in some way. And this is for all academic institutions. We will tell you what we need your help with. Whether you give us a broad area, like I'm an epidemiologist, we will give you an assignment rather than you coming to us saying, this is the work that I want to do. And I think that's been effective for us so far. Academics haven't necessarily always liked it, but I think our community appreciates that form of collaboration in what we call reverse research day, rather than the research the other way.
Well, yes, and quickly. So obviously partnerships with any entity are a lot more complex than any of us have talked about because this is not a new idea and it obviously doesn't happen immediately. And part of it is the kind of issues that Liana's outlined. I think that one of our best opportunities is using these place-based lenses, and we are then collaborating, looking at everybody who's working in that place and using data to drive the priorities for what needs to happen, and that's what's happening in the district office areas. Additionally, we do the same thing. We generate a list at the department of what we consider to be our primary research needs, and we distribute it. And we've had mixed success because all of you in academia know that you're driven by your funding opportunities and priorities. But I think we can focus on a neighborhood and probably achieve the best thing there.
To add to what Mary said, I think we'd have to work more with NIH and CDC to get them to fund the sorts of things that would be helpful, because the typical conversation that I've had with great academic leaders, there's tremendous agreement, there's tremendous interest, but then it's very hard to find the grant that would actually support it, usually because the questions that we're interested in and the methods are messier. They probably would ultimately have more impact, but they often don't fit the narrow NIH guidelines of the tiniest little incremental gain in knowledge that someone could have.
And Carlos, a lesson from abroad as a former dean in Mexico.
Very quickly, Howie, I think there is something that can be learned from the experience of WHO and the more than 700 collaborating centers. What WHO does is make an agreement with an academic institution, usually, or even a Department of Health, and make an agreement for a 5-year plan on what are we going to do. In fact, the comprehensive mental health plan of 2013 that was agreed in the World Health Assembly was the first draft was work with the collaborating centers on mental health.
Okay, fabulous conversation. I could see we could go on for a really long time, but we have to stop and move on with the program for a break. Let me ask the audience to join me in thanking our fabulous colleagues for their work every day, as well as this conversation. Thank you.